Hello, ladies and gentlemen. I've been asked to talk about the new technologies in left atrial appendage management. My name is DJ LAHRS2020. I'm the Executive Medical Director at the Kansas City Heart Rhythm Institute. These are my disclosures. Ever since Professor John Leo Madden from New York has figured out that the left auricular appendage plays a very important role in systemic thromboembolization, and started systematically resecting these things to prevent further strokes in patients with atrial fibrillation, a foundation has been laid down to really closely look at the left atrial appendage's role in atrial fibrillation. It was not until much later in the 1980s and 1990s, with the advent of the transesophageal echocardiography, that cardiologists started paying attention to the connection between atrial fibrillation and the left atrial appendage. And in between, a lot of work has gone into this to resect the left atrial appendage during open heart procedures as a potential prophylactic therapy for recurrent arterial embolization in patients who have atrial fibrillation. And this work was subsequently popularized by William Hargrove from UPenn. So the surgical left atrial appendage occlusion evolved over the years through open techniques to minimally invasive techniques. And in its current form, the AtriClip, which is extremely popular with more than 450 procedures that are being done. We have seen resection and oversewing, stapling, suture ligation, AtriClip, as we talked about, and then tiger paw. Some survived and some didn't survive. Obviously, there was a stroke benefit, and there were issues surrounding fluid retention, especially when bilateral left atrial appendages were resected. Several different approaches and varying success rates were noted. Procedural outcomes were highly variable. Published data was not organized, and incomplete closure associated with thrombus and stroke, and no current large randomized controlled data were present. And it's only recently that efforts from people like Richard Whitlock have helped to really change this paradigm in the surgical space to some degree. With that background, the dawn of the percutaneous left atrial closure was really heralded by innovation from Michael Lesh that was subsequently picked up by Horst Sievert, and the first percutaneous endocardially deployable left atrial appendage closure system called the Plato EV3 came into being. And on August 30th, 2001, about 20 years ago, we have the first percutaneous appendage occluder implanted. A proper study in the form of Plato had happened. And what we realized was that the early experience was marred with some embolizations, instability, and yet at the end of it, the overall benefit in stroke protection was pretty impressive. And this is when Bernie Meyer out of Switzerland started working on using the Emplatzer ASD occluder device as a potential LA closure device. And this was a case of a butcher who was 63-year-old and had frequent bleeding from cuts, ended up with an ASD closure device for appendage closure. And this led to the evolution of plethora of devices. In a sense, it is the mechanical vaccination against stroke, where as a Plato device kind of became history, the fundamental constructs of that have been picked up by Atritech, and Jim Bullock led it, which was subsequently sold to Boston Scientific. And then the entire space really experienced a rapid revolution and transition, and many subsequent devices came into being. The old ASD PFO closure device has led to the Emplatzer cardiac plug, which in turn subsequently has paved way to the Amulet. And then you have the Wavecrest device, the Oclitech device, the Ultracept, the LAHRS, and then the PFMLA occluder, and many others, and quite recently the Watchman Flux. So if you really have to divide these things based on their construct, you have a single lobe design in the form of currently available Watchman Flux, Occlutech, Prolepsis, and Wavecrest. And then you have a lobe and disc design in the form of Amulet, Lamray, Sela, and Ultraseal, um, with different orientation, different implantation techniques, and different set of uh, benefits and problems that come along with them. The nonconformity related to size, shape, and orientation of the left atrial appendage, which could result in incomplete occlusion, evolution, and the micromigration of the device, as it is evidenced by the changes in the degree of compression during lifetime of the device, and incomplete and heterogeneous endothelialization are all issues that one has to take into consideration. So the epicardial devices came into being, trying to fill a gap in what could not be accomplished by then available endocardial device, which was the Watchman device. So Lariat, that was initially introduced by Center Heart, which has now become part of AtriCure, has been introduced in 2009 and has been approved for soft tissue closure, which was used off-label to close the left atrial appendage with a significant amount of data that is generated in primarily non-randomized controlled trials. In 2015, the AMAZE study has been started looking at the benefits of left atrial appendage closure along with AFib ablation in this randomized prospective study, which has completed enrollment, and we are in follow-up for that. Then Aegis came up with the Sierra ligation system, which unfortunately hasn't gone forwards any further. This is again an epicardial ligation system without the use of an endocardial axis. And then AtriClip from AtriCure has done really well. The official count of this device is over 400,000 all across the globe. A very popular device on the surgeons, both during the open hearts as well as standalone minimally invasive procedures. It really simplified the procedure in itself, and the complications of the procedures have been significantly mitigated. The biggest problem we see with this is the incomplete closure with long stumps, more than 1.5 centimeter. Occasionally, you can have central leaks, very high procedure morbidity, longer hospital stay. And of course, it helps in electromechanical exclusion of the left atrial appendage. And there could be limited by anatomy and prior procedures disrupting the pericardium. So left atrial exclusion could be primarily divided into mechanical exclusion, electrical exclusion, and then electromechanical exclusion. Depending on the construct of the device, they can fulfill any of these roles. And depending on what is needed clinically, one may want to choose a device that would fit this particular need. One particular device that deserves mention is the Origin's left atrial ablator and occluder. This has a potential to cause electromechanical exclusion as well as being able to provide appropriate endothelialization without epicardial access. It's in very early clinical phase out of Ireland, and it has completed small animal studies. What you see here is a device that's a single lobe occluded device, but also has radio frequency energy delivery capability all around the circumference that could result in a circumferential ablation around the ostium of the left atrial appendage, creating a transmural lesion and being able to ablate and occlude in the same setting. So to really answer the questions laid down by the frequent evolution of gaps in these endocardial devices, there is a conformable device called the conformer, which is basically made up of PTFE, making it less thrombogenic and relatively smooth. And being made up of foam, this is more conformable than most of the devices are. It's compliant nitinol endoskeleton seems to have ease of implantation seems to be significantly better. The foam LA closure device oftentimes addresses the non-conformity issues that you faced with the original Watchman device, um, even when it is deployed off axis. Um, the, the closure would be significantly improved. It achieves a much better off-axis alignment than the other types of devices ever could. In this canine study, you could see a very nice endothelialization and complete closure of the left atrial appendageal arch with no device-related thrombus, and um, and this particular histopathological specimen clearly shows you that there is a circumferential endothelialization and anchoring of the tissue. And the presence of the porous matrix on the foam actually enables cellular recruitment, tissue ingrowth, and robust endothelialization compared to the other types of devices we have available. So it simplifies the whole process with only two sizes, significantly lower risk of thrombogenicity, having obvious implications to the post-procedural anticoagulation and antiplatelet therapy. And perhaps this could be implanted mostly using fluoroscopy and intracardiac echocardiography, eliminating the need for a double operator and the role of transesophageal echocardiography. The human data, early form of it is very exciting, and something worth to watch for. Then Sierra ligation system from the Aegis Medical employs an epicardial model. You do an epicardial access, so you introduce a sheath based on the voltage characteristics of the tissue. The, the two jaws help you to identify the appendageal tissue based on electrocardiographic characteristics. And this can be confirmed with the help of the transesophageal echocardiography or intracardiac echo without having to perform an endocardial access into the left atrium. And then you are able to pass a nitinol lasso as you hold the tissue with the help of um, the two gentle jaws, and then you get to the neck of the tissue and ligate it off, resulting in appendage exclusion epicardially, both endocardially and uh, not requiring an endocardial access. In this, you can tighten up the suture and close the appendage. So the LifeTech left atrial appendage occlusion, the LAHRS, which is pretty popular in the other half of the world, has many sizes. It has a double membrane, fully recapturable umbrella, and you can deploy and redeploy it in any number of ways. The biggest advantage that I see with this particular device is the ability to close a wide range of left atrial appendages with very difficult anatomies, especially when you have a very shallow appendage or when you have multiple lobes with no probable conformity to a unilobar device. This could be extremely helpful. As it is showcased here, you can actually get into one of the smaller lobes and then be able to completely get a greater occlusion by choosing a device that has a small lobe and a big disc, which is not possible with the other type of endocardial occluders. So the early studies involving the Asian registries and the Chinese studies and the European studies have been extremely helpful. The overall risk of device-related thrombus seems to be low, less than 2%. This is the SELA left atrial appendage occluder. Again, it's a lobe and a disc type of a device. The data on this is relatively limited. Again, this holds promise very similar to the other type of devices. And then you have the old top hat Occlutech LAA occluder. This is a single lobe deployment device. Again, the data on this is relatively limited. And then you have the ultrasound from the Cardia Incorporation Again, this is in various stages of development and clinical execution. So, before I conclude, there are two major studies that are awaiting follow up and presentation. One is the Amulet IDE, which is the randomized controlled trial against the Watchman device, the results of which would be out pretty soon over the next 3 to 4 months. And similarly, the AMAZE clinical study, which is in follow up as well. I think it's important to share a word about the uh, thrombogenicity of the left atrial appendage itself. And there's a nice paper that our group worked with Christoph Bartes in Poland. We studied various thrombogenic factors in different chambers of the heart while the patient is in atrial fibrillation. Uh, and you clearly find that the thrombogenicity of the blood in the left atrial appendage is significantly worse than it is in the rest of the cardiac chambers, clearly highlighting the interplay of the systemic and the regional pro-inflammatory as well as thrombogenic factors that could increase the chances of clot formation inside the left atrial appendage. So to summarize, the structural as well as the functional changes that left atrial appendage undergoes with the continued evolution of the underlying risk factors like obesity, sleep apnea, reduced ejection fraction, valvular heart disease, diastolic heart failure, hypertension. There is significant patchy dilatation and fibrosis, loss of contractility, with associated endothelial changes and inflammation causing stasis and altered platelet function. Combined with the increased wall stress, activation of the Debacker cells, and the re-entry due to patchy fibrosis, all of which could lead to upregulation of the renin-angiotensin activation system, activation of the virtuous triad uh, as an interplay with the complex morphology, with the appendage having a higher arborization index. You would end up having smoke, sludge, and thrombus formation. Similarly, the arrhythmic substrate becomes more manifest with atrial fibrillation and atrial tachycardia triggers that would oftentimes come from it, and electrical reentry due to patchy scarring is another important factor in the role of left atrial appendage in arrhythmogenesis. So, with that in mind, what should the future left atrial appendage devices solve is the biggest question. They should be easy and safe for implantation and accomplish complete closure with no leaks. There should be improved endothelialization. There should be minimal or no device-related thrombus, and they should positively impact the potential aspects of other cardiovascular function, including the neurohormonal function, the left atrial function, and the arrhythmia burden reduction, which are all important in the management of atrial fibrillation and preventing the evolution of the disease and help reverse remodeling. With that, I appreciate the opportunity to be with you, and thank you very much for being part of this program. Bye now.